Bulent, I have some slides which I would like to show. You'll tell me when to and how to do. Bulent? Bulent, can you hear me?
You're on mute, Bulent. But I think you are co-host now, Norman. You should be able to share your slides, I think.
I see. All right. So what do I do? I press.
Greetings to everybody. We are having our 43rd intergenerational meeting with the presence of our distinguished colleague Norman Sartorius. I will try to summarize his CV, but I know nobody needs any news about his who he is. He is known well, very well. I don't think I have any problem. Uh, excuse me.
All right. So should we start or we waiting a little longer?
We are starting. Can you see?
I see Irem Kechichi who has just joined us.
Excuse me?
I've just seen that somebody else has just joined us.
All right. Oh, sorry.
May I suggest, Bulent, that we can
Yeah,
see. Thank you very much for sharing the slide introducing Norman and the
yeah, you can
topic.
see it. Is that
Yes, we can. Yes, it's
all
up.
right?
New Global Challenges to Mental Health Care. But I believe Norman wants to share some
I
slides of
Yeah,
his own. Yeah.
in a minute I'll leave this. I'll
Okay,
try
perfect.
to summarize the brief CV of Dr. Sartorius for the records. I know that all the people who are attending this meeting knows him very well. Dr. Norman Sartorius, MD, MA, DPM, PhD, FRCP, obtained in Croatia. He specialized in neurology and psychiatry and subsequently a master's degree and a doctorate in psychology. He carried out clinical work and research and taught at graduate and postgraduate levels at the University of Zagreb, at the Institute of Psychiatry in London, at the University of Geneva, and elsewhere. Dr. Sartoris joined the World Health Organization in 1967 and soon assumed charge of the program of epidemiology and in social psychiatry. He was also a principal investigator of several major international studies on schizophrenia, on depression, and on health service delivery. In 1977, he was appointed director of the Division of Mental Health of WHO, a position which he held until mid 1993. In June 93, Professor Sartorius was elected president of the World Psychiatric Association and served as president elect and then president until August 1999. In January 1999, Professor Sartorius took up his functions as president of the Association of European Psychiatrists and is now the president of the International Association for the Promotion of Mental Health Programs and president of the board of the Prize of Geneva Foundation. He is, he is an honorary fellow of the Royal College of Psychiatrists of the United Kingdom of Great Britain and of the Royal Australian and New Zealand College of Psychiatrists. He is also a distinguished fellow of the American Psychiatric Association. He is an honorary member of numerous professional associations and advisory boards, both national and international. He is also the co-editor of 3 journals and member of editorial and advisory board of many scientific journals. He speaks Croatian, English, French, German, Russian, and Spanish. He is a living, I can say, living person among us who has contributed lots to psychiatry worldwide. Yes, Dr. Sartorius, thank you for accepting to be with us. Now we are ready to listen to you.
Thank you very much. Thank you for your kind words. I wanted to speak a little bit about the new priorities that emerge in the field of mental health, which not so much for us who are at the end of our career, but much more for colleagues who are younger, will represent their main area of action. Let me just show you a few slides about this. I hope that I can do this well. And while we are thinking about what will be happening in the future, we have to remember that there is a number of major socioeconomic trends which are affecting health. I've listed them here on this slide, and I'll say a word about them. That is the urbanization, which is rampant, the sorry, the commodification, all of these. I'll tell a few words about each of those challenges, which are major and which form in many ways and define what we are going to, or what you are going to do in the future. Starting with urbanization, I think it has been the most rapid period of urbanization in the world, and it has created a variety of consequences which we never expected. It produced, on one hand, a number of what is called dormitory villages. These are villages next to big towns in which people come to sleep and maybe spend Sundays, but basically they are not villagers. They are, in fact, town people who come there to spend a little time. They have no idea who their neighbors are or what they should do. They are not willing to contribute to the world of the village in any way, and they are basically avoiding contact. They want to have their peace on the thing. Then there is a number of, particularly in some countries that are not so far from Europe or from, there are what is called being the invalid villages. These are villages which are from which young people, men and women, have left to go and work in towns, but the villages have remained empty. They now have elderly people who are disabled in one way or another. They have children who are mentally retarded or otherwise incapacitated, very often cannot go to school. They have no source of income. The agriculture which they used to have is neglected, and they live from what their younger members of the family send to them from towns, where they have found very often a miserable employment. A very classical form of that is also the rapid growth of hotels and other tourist arrangements along the coast, which has emptied the villages, particularly in countries such as some of the African countries, but also on the coasts of the Mediterranean, where the young people have gone to the shore to work with the tourist business, but the elderly and the disabled, etc., have stayed in these what one can call the invalid villages. While this is happening with the villages, at the same time, towns have grown into a huge accumulation of slums, which are rapidly increasing. 95% of the population of Argentina, for example, has moved to towns now, and most of it has happened in the last 20 years. And while these slums are growing and becoming more and more populous, at the same time, some of the people who are richer have separated themselves from the others by very often by barbed wires and by walls with people armed with guns who make sure that nobody from the poorer part of the city comes to the richer part of the city. If you go to a town like Manila, where the population has grown very rapidly, you will see that there is a territory which is reserved for the more people with more money and with a little bit with a decent employment, etc., living there. And there are people with machine guns on the entry to this village, making sure that none of the people from elsewhere comes in there. And of course, uh, the community as such does not exist in villages anymore because these people who are left there are not a community which has a capacity to act. And in towns, these privileged territories are complaining about loneliness and isolation while they are separated from everybody else. So that was the first of the major trends. The second one is the trend of commoditification. Basically, it means that it has been now customary that everything is being considered as being a commodity and can be valued in money. So that healthcare is also a commodity. It is like sugar or like timber. You can buy healthcare and you can sell it. And a good hospital is a hospital which makes profit. It's not any longer a hospital from which people come out happy that they are healthy and remembering their doctors as being human beings who help them. The hospitals as such have become quite clearly a commodity which is being sold from one owner to another, very often reserving beds for some particular type of patients who are likely to provide more money when they are being treated there. And I think this is for in our field. But everything else is being also now expressed in monetary terms. And empathy and moral duty and humanitarian drinks are being very much considered as being something secondary and therefore unnecessary. Another major trend that has been recently present is what has been called horizontalization, in which people live in horizontal layers without vertical communication. So adolescents speak to other adolescents. They often speak a language which the elderly do not understand anymore. The elderly speak a language which they understand, but the younger ones don't know what they're talking about. And society as a whole is now organized horizontally, where people from the same profession speak together and get together. But the vertical communication is practically died, where the grandfather would commit some knowledge and tell stories to the father and the child and the grandchild and everybody else. The whole communication that is vertical, which has been tremendously important because of a transmission of culture and a transmission also of empathy and other feelings, has now been gone. And I think that the vertical transfer of knowledge is missing now. You see very often that people have to relearn things which have normally existed many years ago, but have not been transmitted. The other point, of course, for some of these groups, the horizontalization means other things. For example, the elderly, whose only contacts are other elderly, are losing very many members of that elderly group, and therefore they are becoming also very lonely and disabled in their own field. Another major trend that has been present has been the fragmentation of labor, but it's the fragmentation of everything. In that, what was previously satisfying people and giving them a feeling that they're achieving something has been that they have taken a raw materials and produced things, and they could see the production creating something. Nowadays, as that is starting in the 1930s and 40s with industrial development, nobody sees the product of their work any longer. They just see the piece in which they are currently working. This is most obvious in factories where workers are working on a particular part. But it's also true in medicine, where doctors are seeing only a little piece of their work. Then they have to send the patient to various kind of other investigations, other consultants, etc., so that they do not see their work as a continuing thing in which they see a patient, offer him help, patient gets better, and they have a human relations with that person. They see themselves only as contributing a minor part in a much larger process. And the consequence is that they hate what they're doing, and that we have the epidemics of burnout, particularly among younger people in many of the countries of Europe, but probably elsewhere as well. Demographic structure has also been changed. The number of elderly has survived, and now they are living there, but they are not living a healthy old age. They are living an old age with many diseases. And I think that it's becoming a very interesting way to think of what one could do to reduce the diseases in the sort of in the elderly, which very often for which very often there is no money and no opportunities. And then there is a change of demography in another sense. Previously, we had three clear groups. We had children, we had adults, and we had the elderly. But now, over the last 30 or 40 years, two new groups have created themselves. One is the group of adolescents, which are neither children nor elderly, nor adults, and whose social role is unknown and undefined. And they spend 10, 15 years without any social obligations to contribute to society. It's a very curious group that has existed. We do not know what to do with them. We do not know how to treat them, how to help them, how to guide them, because they are a group that is defined in this way. And the other group that has come into existence is the not so old. Previously, at the age of retirement of 65 or so, people lived very short while after death. In fact, the expectation of life at the point of introducing retirement in the 19th century has been very short. Life expectancy in Germany, for example, when they introduced the pension system, was 3 years. 3 years after a person received his pension, he died for one disease or another. Nowadays, the expectation of life after retirement is 20 years. And the first 10 of these years are people who are not young anymore, but not old either, who have physically very often in good health, mentally as well, quite willing, and who are seeking something else. And they start working again or they do other things. But one thing which they do not do, they do not stay at home to look after their grandchildren. They do not stay at home to do other tasks. And so the home is now becoming an empty space because the children are at school, the parents are at work, and the not so old are also outside somewhere, sometimes employed and sometimes just being outside. The very old, however, that is the people of 75 and over, are very often having many diseases, and because of that need carers whom they do not have. Now there have been other changes as well. The rapid change of partners, which has become typical for many European countries and elsewhere as well, where a single child may have 3 or 4 mothers in the course of its growing up, has created great difficulties in shaping a personality, a cultural personality for that person. And then, of course, there is a variety of other problems that emerge because of the high rates of divorce and new forms of partnership. We are all very proud and wonderful with artificial intelligence and digitalization, but we have to remember that digitalization has negative consequences as well. The benefits of digital tools are unevenly distributed. That is, elderly people cannot really learn how to use them, and very poor people do not really have the money to buy it and stay with the modern products. In medicine, we know that digitalization has contributed massively to a dehumanization of medicine, so that the relationship between doctors and patients have become much less warm, much less empathic, with much less humane qualities. Now we have been thinking that perhaps it will be possible to use digitalization to improve collaborative care, but it's not been told. We talk, or most doctors now will talk to a machine somewhere in center, but their contacts with other colleagues have not necessarily improved. It has improved in the sense of minor information exchange, but not in terms of emotional strength. And of course, the fact that we are relying on technology completely means that if there is no electricity, the whole system stops. And the consequence of this can very often be terrible. Now, despite of the fact that we have these tasks that we had before, there are still many things from yesterday which we have to consider as being important. Let's sit here: vaccination, contagious diseases, perinatal care, chronic disease care. And I think that some of these problems have been reduced, but they're still present, very often hidden. Now there are new problems as well, which have emerged. The first of those is the carers, people who look after other people, the elderly. They are gradually breaking down. They have work to do. They have very often to go out of home for work. They cannot really look for people in this sense. Another major problem, which I mentioned earlier as well, is the loneliness. In some countries, for example, Japan, found that loneliness is so terrible that they had to think of a ministry of loneliness which will look after people who are lonely. In some instances, they found that people who died have not been discovered as dead for years after they have died, because nobody ever came to their home, nobody looked who they are, where they are, or what they do. So that this isolation and loneliness are a major problem for many countries and becoming problem everywhere. Then there is the problem of burnout, which is a new problem, but very severe. Young psychiatrists, for example, in Europe, have been shown to have up to 50% of them have signs of burnout because they feel so terrible in their work. They have no feeling of satisfaction of having taken a patient, following him up, dealing with the patient, having a healthy person in front of them with whom they have established an empathic contact. They have just contributed something, and they do many hours of this meaningless activity which they now have to perform. But groups have also become burnout. Families have been decomposed, and that has led to the fairly inadequate childcare for many families. And the transmission of culture and of moral duties to lower generation has been significantly disrupted precisely because of the factors that I mentioned earlier. One of the consequences of this lack of moral structure is also a significant growth of new forms of dependence. Dependence on internet, for example, which is the only source of contact for many children and many young people. Gambling, where it is so much hoped that a reward will come, at least some kind of reward. It's not many of the other types of rewards that have been previously offered to children and to young people are not offered anymore. And then the new drugs, of course. But at the same time, while this is all happening, our neglect of public health has led to an increase of the old monsters like tuberculosis and measles, which are killing people unnecessarily. Now, of course, some of the problems which we now have will be resolved by better medications, which we have, by better tools, traditional and new ones. And then there will be also the traditional way of, and more staff functioning traditional way will not be able to be resolved. Now, here is what I suggest for the future as being our top priorities. Number one is to think about support to informal carers. They carry 80 to 90% of all health care on their shoulders. We see a patient very shortly. We are very proud that the duration of stay in hospital is 3 days, which means that the duration of stay in the family is very long. And that many people have to sacrifice their own career and their own progress in order to look after people who are disabled. We are not recognizing their role. We are not, for example, inviting carers, the family members, to come and teach to medical students what it means to look after a person with dementia, or a person with schizophrenia, or a person with a severe heart disease. They could teach us a great deal because they know it. They're doing it all the time. There is practically no country which gives decent financial support to carers who have to stay at home and therefore they cannot make money, which in the current situation is very often a tremendously serious shortcoming. We have not thought of ways of providing health care to carers. They're treated like anybody else, but they have very often much higher rates of physical and mental illness. And they should be offered special health care possibilities. We should also offer them opportunities to learn about the disease and to learn about things that are happening. We are not supporting the care organizations. And very often, if you ask a doctor, which is the care organization in your town, they don't know. They have never bothered to find out whether there is an organization of parents, organization of brothers and sisters, of people with mental illness. We don't know who they are, where they are. We are not working with them. Now, so that is the first priority that I thought was important. And that was the priority of thinking about how do we maintain the power of carers, because without them, our health system will go to pieces. My second one, I think, concerning is prevention of burnout. And I think that burnout has to be significantly recognized. And there are various measures which we can specifically undertake, including the leadership of various categories, including an examination of the way in which rewards are produced, thinking about the organization of work in our own departments to make it interesting and valuable, not only for the patients, but also for the people who work with them. And burnout is not only a disease that is striking people in the healthcare system. We should think of ways in which we can engender a reaction in towns and in the society in general that will reduce burnout. My third suggestion is to almost completely reverse the training of healthcare workers, including psychiatrists. Number one, I think it would be extremely useful if one were to select people who will become doctors a little bit more carefully. Many people go to medicine thinking it's a wonderful thing. They are accepted, and after 3 years or 4 years, they find they don't like it very much. Then they graduate, and they are very unhappy in being a doctor. So they go into some kind of a sub-profession of medicine which has no contact with patients. They go into radiology or I don't know what, or into administration because they've been unhappy. But it's a waste of our time to train these people as doctors. I think that we should think a little bit, at least we could do is one could have for example, a interview with the candidates for medicine to see whether they are in morally and material, by personality and otherwise likely to succeed. Or if not, what can we offer them instead? The advice to a young person who's entering into medical or other schools is tremendously important, neglected at present. Second, all of the doctors should be trained in certain skills which they do not have. They should be trained in communication skills. How do I speak to people so that they understand me? How do I speak on television? How do I speak to other colleagues? What is the nature of leadership that I have learned? How do I lead teams if I've never been before that trained on how to lead teams? And there's a variety of specific tools and specific ways of training people to learn skills, professional skills, leadership skills without any difficulty. We should also think of trying to diminish the distance between different members of the health team by having joint training for certain topics and for certain times. For nurses and doctors and social workers and lawyers, they should have some training together because they will learn to each other. They learn the same thing, but they will also learn about other members of the health team and establish relationships that will be more respectful than they are today. Today, the respect that doctors have for nurses or that for social workers, etc., is not very high, which is a great pity because they're working in the same situation. There is a variety of measures which can be taken to prevent burnout, and that should be something that should be financed and done. And we should ensure that there is a regular short update training, 2 days maybe every 6 months, or 3 days at the end of the year, or whichever, to bring people up to date and to keep them happy in the sense that they know what they're doing and that they are in command of their skills, in command of what the work are doing. Now, the fourth type of priority that I want to put forward to you is suggestions to prevent side effects of social change. For example, it would be of great importance to think of psychiatrists participating in the organization of perinatal care, because women at the point when they are expecting a baby are particularly likely to listen very carefully to what you tell them. So it's an ideal time to talk about ways in which the family can be structured and better organized, in which problems can be avoided, in which children can be educated, a variety of things. And working together with perinatal care agents would be of great importance for us. We should think of ways in which we can change the school organization. For example, the beginning, one cannot do everything at a time, but at the beginning, one would at least could establish a contact with teachers to see to what an extent there are measures that could be taken that would not significantly influence them, but would help to organize schools a little better and prevent these bad events that are now happening with bullying, violence in schools, absence from schools, high rates of dropouts, etc. A simple measure to prevent high rates of dropouts would also be to ensure that children have a good, proper control of their visual and hearing capacities, which at present is not done. In Australia, in particular, but also now in some other countries, there have been measures such as creating safe spaces for adolescents who can meet there, who meet other adolescents, and maybe have advice or access to a person who is knowledgeable. You may wish to look at these safe spaces descriptions. They are wonderful places because they help these adolescents in particular to grow up much better. And then there is also our efforts to promote and to speak for ways in which we could ensure that the informal contacts stay and that society remains together rather than broken up into hundred pieces. One of the things that has been done in some countries have been coffee houses in which people meet and have a cup of coffee together. Maybe in Turkey today that still exists, but for many other countries now, if you look at a country like Switzerland or Germany or wherever, an elderly person cannot speak to anybody at all, anytime, any place, because they are separated by the way in life they are. There's been a wonderful example of the change of social work, which I think is, for me, a good example of how the work of some health professions should be reshaped. In Holland, the social workers have been told, you're not going to be in the office anymore. You have here a list of 15 families, and you're going to look after them, which means that you have to go to their homes, to sit down with them, to talk with them, to help them in anything they want. Because each of these anything contributes to the situation in which you can be healthy. So they can help them in submitting the tax reports, they can make contacts with them, with hospitals, they can help them in other ways. It's as if suddenly the family had obtained a young, very competent son who is able and willing to do everything that the elderly people in the family do not know to do or do very badly. The social workers who have done this, who are no longer coming to the hospital or to a facility, who are spending half a day with family, one after the other, are expressing that they've never been so satisfied in their life with their work as they are now. And the families are enchanted. And maybe something like it could be done in other places as well. We should also think of ways in which we can bring up children, because it is of essential importance to think that the first few years of child's life are the ones in which all the concepts are created and the child's personality is shaped. Now, would it be possible to have both parents having part-time work perhaps during that time, or at least one and then the other, or some other way, because we are neglecting the crucial years, 1, 2, 3, 4 years, in which all the concepts are formed, attitudes are formed, and the personality is in fact made up. And we are leaving it to go with no unknown nurses and with unknown people. The terrible example of that was recently I learned about children in Saudi Arabia whose parents cannot speak to them because the children don't speak Arabic. The only language they speak is Filipino, Tagalog, because the Filipino nurses have been looking after them. We should also be actively involved in thinking about healthcare laws to see how they are constructed. At present, if you ask a normal doctor about laws, they practically do not know where they are and they've never read them, although they're actually relevant to them. And I think it's of importance to think not only of adjusting these laws to the new society, a new reality, but also how to make sure that they are adjusted and adapted in the course of time. And of course, we should think of support to the elderly a little bit differently, because at present they must have a physical disability, but the fact that they're elderly is already enough of a disability for many of them. So, dear colleagues, I think that the impact of socioeconomic development and technological advances has changed the world in which we are living. And I think that many things which could make life better for everybody are possible and necessary and will depend on people who are now in chair and even more on colleagues who will be doctors tomorrow. How to do things? There are so many measures that nobody can say, I cannot do anything. One or the other of the things that I've listed and many more could be done if he started to think very clearly, how do I do something to improve the life of people as a doctor and as a member of society? And of course, there are many measures that we can do, and all that we need to do is to decide to use them. Thank you for listening to me.
Thank you very much indeed. You have given us several bad news first, but then suggested enormous things to do. While at the beginning I was trying to introduce Dr. Norman Sartorius, I couldn't find the real word which I had in mind. I would say he is a living legend, and he has proved what I was trying to say but couldn't do. Well, I have several questions, but before going to that, let me ask the audience what they would say, what they would like to react to this excellent presentation. Please, Dr. Afsal.
Well, thank you very much, Professor Koskan, and it is always a pleasure to listen to Professor Sartorius. Words of wisdom, what we need to do, and what we as a professional organization should really work on that. I think the contents of Professor Sartorius' lecture is really the take-home message, not only for our youngsters, but also for those who are at the helm of affairs for teaching and training our postgraduate students. I mean, these are some of the issues which he has highlighted. How many professional organizations have been able to get it discussed among themselves, tried to develop some guidelines, and efforts to get it implemented? I think this is probably the best way forward, that based on Professor Sartorius' realistic scenes, realistic what is happening on the ground, I think we need to really involve and ask the professionals that, look, please consider this, implement this, and try to make all these issues as a part of the future training. Thank you, Bulent.
Undoubtedly, it is precisely the training time where professionals, future professionals, could be offered opportunities. And if they are not offered opportunities, they should take opportunities to see to what an extent they can become engaged in some of the activities that I mentioned, because they will otherwise grow into a very unhappy profession.
Any other contribution, especially from young colleagues? We are all young. Rodrigo, you may say something.
We're all young at heart. I have a lot of accumulated youth, is how I present it. No, thank you very much for that very thought-triggering presentation. And as Bulent well said it started with some very unfortunate truths of realities we are facing. But luckily also with some potential ways forward. I I am particularly hopeful in in in in the potential benefit of keeping all this in mind during training and in the transdisciplinary necessary approach that we're going to have to take, bring in various professionals that in the field work together to train together and share from that starting point clear expectations and role distributions and conversations about how to face all these facts. Um, and yeah, and I also share the the the, the this double-edged sword that digital psychiatry or digital tools are bringing. They are indeed bringing some very good possibilities with them, increasing access to things and bridging gaps. But yeah, it's a double-edged sword. Not only in terms of communities that might not be prepared to use these tools, but also in terms of professionals that, as it was said, that might not be able to um, navigate them. And if the professionals do not feel comfortable, then they won't be able to make the communities feel comfortable if they themselves don't feel comfortable using. And it might finally contribute to that burnout that it's already there with this additional burden put on top of professionals. And then, so yeah, yeah, my goodness. Lots very thought triggering indeed. Thank you very much, Professor. Yeah.
Thanks. We are having new friends among us. Öykü, would you like to say a few things?
Thank you so much. It was a very wonderful presentation for me. And I guess we should consider health as a not just a health provider system or health system. We should consider it as a lifestyle. And your presentation make a great point about that. And very thank you.
Yeah. İrem, Ahmet. Yeah, Ahmet, please.
Thank you for the presentation, firstly. It was a very thoughtful presentation for me. I have a question about vertical, basically, communication. And I have a theory about why it is basically going extinct. There is a lot of empathy between younger generations and older generations, but I think that is going extinct because of economical situations. Older generations think economical situations like old past, like as they were young, but it's a lot changed. It has changed. It has become a lot harder to like buy a house, basically live with your needs. And younger generations think as these economic situations, but don't see older generations thinking like these economical situations. And basically, older generations are judging younger generations like the older economical situations. So younger generations are judged a lot of older generations, a lot by older generations, and they're fed up with it. Especially, I'm fed up with it because I have a grandfather and he's judging me a lot based on my economical situation right now. And I think this kills the empathy between older generations and younger generations. What could we do about this situation?
I think the answer to that question is extremely individual because people are so very different, and the history of their development and history, their growth, and their own personality are very, from one person to another, very different. But I think one of the things that has been in many places found to be useful is precisely where the older generation find themselves rather incompetent, and where the young could be the teachers of the elderly. I'm taking for example, the use of this machine, the telephone. Uh, Somebody of a younger age has this machine and conquers the world with it, and the person of my age sees this as a bloody telephone and nothing else, and therefore only phones and cannot see all the other things. But talking about the ways or trying to show people something that is useful for them, like in this instance would be learning how to use the modern technology, can very often, if introduced, create some bridges which have been forgotten or left out. And I think at the same time, thinking of inviting an elderly to show something, or when I say elderly, that means so your father legend. The older ones still are even more difficult. But I think inviting people to show you something, even if you necessarily think it's different, may be of tremendous. Because when you speak to elderly people or people and adults, they say that our children don't respect us anymore, uh, which is not true. It is just that there is no contact with them to show any respect to anybody. And I think that it really is in a way, one should encourage the younger ones to take the first step, although it's not expected they will do it. Expected that the father, mother, and whatever will do the steps. But very often you have to correct them because they're living in an age which is gone. And to bring them back into today's age is a very difficult proposition.
May I add something? I think that actually, and I don't count myself as I really don't count myself as one of our young colleagues, but um, when you, Professor, when you were discussing the new communities that have come out of these geopolitical economic changes that we see around the world, um, one that I did not grow up with is also this social media, online communities. That is one community that did not exist when I was young, but it exists now, and something also to keep in mind, and that and plays a gigantic role in how people feel and how they develop their identities and work out through isolation in this more individualistic and world. And that is a learning that older generations don't. Yeah, it's important bridging that. It has to be bidirectional learning, and always all parts of the I'm thinking here about training and education. And when in training and education, both parts are bringing something to the table, and it has to be bidirectional. And younger generations are bringing something that hopefully is also learned. Yeah, sorry, I'm just monologuing, but no, thanks for that input, Hamid. Yeah.
Yeah, the one thing that probably is perhaps useful is one would like to change the world, and that is fine. But it's very useful to start with one person who is next to you to see whether one can do it with one person, create a link somehow, but and then maybe gradually increase the number of links and create a common area in which you and a group of people have re-established the links and make them alive and active and effective. So that while we cannot change the world, but I can at least change my neighbor. And now I have a good relation with my neighbor. Maybe the two of us can meet someone else and we will create a different. So, in a way, one of the tasks that is before us, all of us, is not directly medical task, is really to rethink of of bringing the societies back together, which is currently falling apart. Now, when you speak about education and training in medicine, in particular medical education, one we are currently seeing that the students spend a lot of time to learn the techniques, but they spend very little time talking to patients, to speak about with a patient, not for 10 minutes, but to speak for maybe every day or every second day for 20 minutes. Hello, how are you today? And establish a personal relation with patients, because patients can tell you about their illness much more than anybody else. So I think that in a way one has to do this extra step of trying to establish a relationship with other people who are not well, to learn about what worries them and to learn how to speak to them. Uh, I remember from my youth a one example which has stayed with me forever. That is, there was a lady who was an elderly lady who was refusing to accept an electroconvulsive therapy, which was done properly with anesthesia and everything you want, but she wouldn't do it. So I came, they asked me, go and speak to her, please. I was just a young doctor. So I spent half an afternoon talking to her. We walked together in a garden and I spoke to her, and then we walked again and this and the other. So 2 days after that, they offered it and she accepted. And she was doing fine. And uh, what was striking about this, that after this has all happened and she started speaking again because she was mute, she didn't want to speak to anybody, we discovered that she did not speak my language at all. She did not understand the word I was saying. But what she did understand, that here is this young doctor who is very nice, who walks with me in the garden, who is a nice person. I can trust this person. In a way, we created a relationship. And I think that we are often forgetting that this part, the words as such, are only a small part of the total relationship. And that creating this rest, the rest of the relationship is much more important than what we can say.
A very good example indeed. Well, I have several questions about the things you have suggested, but there is also another very important challenge, global challenge. What would you like to say about that? The authoritarian tendencies in administration globally. Would you like to say a few things about that? What we can do?
A tendency to what? Sorry, say it again. A tendency to?
To administer in an authoritarian way globally in different nations at different administrations,
Well,
governments.
as one says, it's very difficult to change other people. It's much easier to change oneself. And we should start with oneself, I think, in this instance. Think, am I, in fact, talking to these people in the right way? I'm now a young doctor. I'm very impatient. I must go do this, the other. But is this the right way to do it? In a way, very often we are not aware of how we behave And since we are not aware of how we behave, we in fact behave in a way that decreases the communication, decreases good relations and everything else. And the first step in improving is to think about myself. What am I doing when I meet somebody? Do I smile or do I not smile when I meet other people? Do I offer to help them or not? Do I, in many ways, examining oneself very often makes you discover things, at least that for me, discover things which can be improved, which in turn improves relations with others. I think that very important is to start with oneself. And very important is also to do useless things. You know, there are things which require your attention, etc., and which are very important, and we are engaging in those. But there are very often other things which seem to be useless, like a game or something like that, which we say we don't have time for that. We have to do other things. Well, it's not true. We should have time for both useless things, things that are not particularly constructed or well seen, and spending an extra hour sitting and drinking coffee, although we are busy, or whichever else may be of very importance. I remember one example of which I think was a doctor from um, Costa Rica, and he was a gynecologist, and he required when he was having an obstetric department, and women would come in, the pregnant women, and then he has asked for volunteers. This is women from the village who would be willing to spend a day or two with the pregnant woman before the childbirth, just to talk to her, just to be there. So some women said, all right, we'll do it. They came and they would be assigned this particular lady who is expecting a baby, and they would, no instructions, just be together. And they were together and they were talking about something and walking a little bit or just sitting there drinking coffee, etc. The consequence of these day or 2 days contact with the pregnant woman was a 50% reduction of childbirth time. The time for the child to be born fell to about half because she had this period before that with somebody else, in which some of the worries which they have been ventilated, and these women sort of succumbed down a little bit and became relying on this other person with whom they spoke. So what I want to say is that very often it's simple things that we can use to improve situation.
Thank you. Thanks a lot. Maybe I couldn't express my real question. I was wondering if there would be anything as a citizen of the world we can do anything for decision makers all around the world. They have authoritarian styles. They make decisions unbelievable. I am wondering what people will write in 100 years' time in history about this period we are going through. Is there anything as an individual, for example, I can do for this other than voting?
Yes. Well, I think that one thing that is very often quite useful is to look at one's own behavior and look at one's own life. In what way can I be more socially useful? What can I do for other people, etc.? Things of this kind, because the change really, uh, even revolutions do not start by going out on the barricades. I think that really the place to begin is oneself, to see to what can I do about myself, either to adjust to the situation in which I am because it cannot be changed, or to change the situation, or maybe to go some other place and not and avoid this group that I don't like at all. I think that becoming more aware of one's own action, one's own behavior, one's own wishes is tremendously important for change, not only of yourself, but of the society as a whole.
Thank you. Thank you a lot. Is there anything else before we close our very important session with Dr. Sartorius. Irem has written she cannot speak due to her place in the hospital. And Bartu, would you like to say anything before we close? Can Cimilli is with us, but doesn't, I don't know if he is with us anymore.
Thank you for all things, both presentation and comments.
Okay.
All
Well,
right.
what would you like to say while we are ending, dear Dr. Sartorius?
Well, good luck to all of you, all of the students, and I hope that what we have done today may lead you to think a little bit more about what yourself, what you are good at, what you can do very well, and become proud of that, because that will help you to overcome the frustrations which are undoubtedly before us.
Thanks. Thank you very much.
All
Thank
right.
you for being with us.
Thank you. Thank you very much. And congratulations for doing this intergenerational meeting. Thank you.
Thank you. Thank you. Let me take a picture before we close.
All right.
Yeah.